Ready?
All right. Okay. A very good evening to all the participants for today's webinar, where we have our greatest pleasure to invited two good gentlemen, Dr. Abdülkadir Göksel, as the speaker for tonight. He is a prominent rhinoplasty surgeon from Istanbul, Turkey, and also a dear friend, Dr. Aik Ming from Malaysia, a fellow plastic surgeon, also a specialist in rhinoplasty. So today the webinar is about crooked rhinoplasty, nose correction with preservation rhinoplasty, presented by Dr. Coxell. Okay, and without further ado, Dr. Aik Ming, as the moderator today, I will pass the baton to Dr. Liao.
Okay,
Dr.
thank
Liao.
you, Mr. Eddie Liu, for the brief introduction. Greetings from Malaysia. And this evening, we warmly welcome Dr. Abdülkadir Göksel from Turkey and all the participants from around the globe. The time zone may be different, but our enthusiasm is still the same. Want to learn something from Dr. Göksel. And this is our fourth webinar series on rhinoplasty, organized by Mr. Eddie Liu, founder of FATS. And I'm honored and pleased to introduce to you Dr. Göksel, a renowned world-class facial plastic surgeon from Istanbul, whom I have also learned a lot from him through education activities organized by the Rhinoplasty Society of Europe. He's one of my great teachers. And let me briefly introduce Dr. Göksel to all the audience here. Dr. Göksel hails from three generations family of physician in Gaziantep, Turkey, if I pronounce it correctly. He's a board-certified ENT facial plastic surgeon based in Istanbul. He is recognized worldwide for his expertise in aesthetic, functional, and revision rhinoplasties. He holds the European Board for certification in facial plastic surgery, plastic and reconstructive surgery, and served as a general secretary for the European Academy of Facial Plastic Surgery. And also he has served as a president and co-president of Biennial Structure Preservation Rhinoplasty Meeting. I think there's one coming up in November. And he also a founding member of the International Rhinoplasty Research Society and also an honorary member of the Russian Society of Plastic Surgeons. He's frequently invited to the international congresses across Europe, Asia, Australia, and the United States to lecture on structural preservation rhinoplasty, nasal tip surgery, complex revision cases. In addition to that, he regularly hosts surgeons from around the world in Istanbul for live surgery, training, and advanced education program. Without further ado, may I invite Dr. Göksel to start his lecture. Dr. Göksel, please.
Thank you, Dr. Leo. Thank you very much for your kind words. And thank you, Eddie, for bringing us together in this webinar and also upcoming course in Thailand. And it's my pleasure to be here with you. And I see we have big number of participants now. I want to share my presentation. And today the title is Crooked Nose, Analysis and Indications. And mostly I'm going to talk about how I deal with crooked noses with preservation rhinoplasty. When it comes to crooked nose, it is one of the hardest part in rhinoplasty actually, because once you are operating crooked noses, it starts with the examination. The analysis is one of the most important point, of course, and you have to decide to make it with structure rhinoplasty or preservation rhinoplasty. Basically, we have limited time. I can talk about this issue more than 2 days maybe, because it's a very complicated issue. The middle wall tip plasty, the bony pyramid, the septum, the around the soft tissue envelope, even muscles can be an issue in crooked nose correction. But basically, I'm going to talk about preservation rhinoplasty based crooked nose correction today. As Dr. Leo mentioned, we have the big meeting also in November in Istanbul. I want you to invite you to Istanbul between 19 21 November, structure preservation rhinoplasty meeting. So let's start with the analysis. Everything starts with the first consultation, actually. Patients complain about crooked nose. Sometimes it is very obvious, sometimes it is not obvious. For example, this is an interesting case I wanted to share with you. This case, this lady, young lady, came to my clinic and she asked me to make correction. Actually, she had operation before. This is for revision rhinoplasty. She was complaining about crooked nose and it was not obvious. When she comes to the clinic, when you look at her face in daylight, or this is the photograph with the paraflash, you cannot see what she sees and she complains, because most of the crooked nose patients, even normal rhinoplasty patients, they don't see their nose with their eyes. They see their nose with their hands because tactile sense gives more information to our brain. Look at this photograph. It was taken same time, same day. And the first photograph, you cannot recognize, you cannot understand why she complains about crooked nose. And the second photograph was taken just 1 minute later with the flash. And you can definitely understand that she has problem on the base of the pyramid. So when it comes to crooked nose, the analysis starts with the photography. Analysis starts with your tactile sense. You have to touch, you have to understand the base of the pyramid, not just the dorsal aesthetic lines, not just the tip defining points. It is very important educational photograph here that you can understand. The photography is very important. Not just the paraflash photograph, not just the cell phone photograph with different lights in different positions. Sometimes the dynamic photographs are very important, and we have to standardize our photographs when it comes to crooked nose because everybody has their own comfortable head position. Some patients has some tilted head to the right or left. So if you want to compare before and after, you have to make some guideline. For example, this face is totally asymmetric. She has crooked nose, but the middle portion of the lip is not on the middle portion eyebrows. And when you make the straight line on her face, you cannot understand where is the straight midline point of the face. That's why we have to understand where is the midline and which midline should be our guide. Should it be the skeleton midline or the soft tissue midline? Because it is totally different. When you look at the skeleton, sometimes you see the midline of the maxillary bone on the midline, but the nose looks crooked just because of the tip defining points or the dorsal aesthetic lines. And unfortunately, there is no this kind of straight face and straight nose. Almost 80-85% of our patients has a little bit crooked nose because of the asymmetric faces, because we are dealing with asymmetric faces. And when it comes to crooked nose correction, if the midline of the soft tissue is really straight, we can get the result. We can achieve our result and we can tell our patient that I can make it better. But sometimes this line is not straight. As you see here, midline of the lip, soft tissue envelope, sometimes is not on the midline of the eyebrow. So you have limitations. That's why it is very important point. Everything starts with the examination. Everything starts with the analysis when it comes to crooked nose. If you give this information to your patient before the surgery, it's an information from their point of view. But if you tell them after the surgery their face is not symmetrical, the midline of the lip is not on the midline of the eyebrow, from the patient's point of view, it's kind of excuse that you're saying because you couldn't make straight. Because it is very important to tell everything before. Because if this patient has this asymmetry, you have to warn them that the nose will be always a little bit crooked. So we have limitations. Or you have to work on the maxillary bone or mandibula, then you have to change everything, which is not our title today. I'm just going to talk about the crooked nose correction. And what I recognize by the time I do a lot of cadaveric dissections all over the world. I took a lot of photographs of the skull. I have some photographs here I want to share with you. Look at the anterior nasal spine. The anterior nasal spine is, interestingly, if there is no trauma, is always on the midline of the maxillary bone. So look at the anterior nasal spine on the left photograph. Of course, the base of the nose is crooked, tilted. Ethmoid bone is crooked here. Ethmoid bone is straight on the right side, but base is crooked. So septum is crooked, but the internasal spine position is almost on the midline. So when it comes to make correction, we can find the midpoint, bony base, and we can make our own groove straight direction. Then you can use the hand saw, you can use the rasp, or you can use piezo. But look at all the skulls. These are different skulls, but septum is always tilted. Ethmoid bone is almost always crooked, but the midline of the intranasal spine is on the midline of the maxillary bone. So this is very important point that we have to remember. And look at this face. Look at this patient's face. It is asymmetric. And of course, it is not the must, but most of the time, when you look at the asymmetric faces, one side of the face is shorter than the other, and the nose follows to the shorter side. Look at this face. Left side is shorter, and nose goes to the left. And this kind of patients are very difficult patients to treat with structural rhinoplasty because this asymmetry comes from the bony pyramid and ethmoid bone asymmetry. And when it comes to preserve a structural rhinoplasty, once you separate everything from the ethmoid bone, you have a risk to collapse the middle vault. So this kind of patients are the best candidates for preservation rhinoplasty. Look at this face. The right side is short, nose goes to the right. So we just need to tilt all the nose to the midline of the face, of course, because face is also asymmetrical. But on the other hand, as I mentioned, if you ask me why we need to learn preservation rhinoplasty, I think these patients, crooked nose, asymmetric face patients, are the best candidates and are the reason to learn preservation rhinoplasty. It doesn't matter if you're dealing with the hump or not. And it doesn't matter if you're working in Asia or Europe. So when it comes to crooked nose correction, you just need to tilt this asymmetric face and the nose to the midline. So why it is easier? Because when we do preservation rhinoplasty, we are preserving the bony pyramid and all the dorsal aesthetic lines most of the time, and we need to tilt the pyramid to the midline. You can do high septal strip, you can do low septal strip. We will talk a lot about this kind of different techniques in preservation in Thailand course. But when it comes to crooked nose correction, I prefer low septal strip because low septal strip gives us opportunity to separate the old quadrangular cartilage from the ethmoid bone and the maxillary bone and the vomer. So this quadrangular cartilage is released from the bone around. Then you can tilt the pyramid to the midline and one side sagittal osteotomy as you can see here. Another side horizontal osteotomy is very helpful to tilt the pyramid to the midline from left to the midline or from right to the midline. And when it comes to sagittal osteotomy, of course, sagittal osteotomy perpendicular to the maxillary bone is forbidden to make it in structural rhinoplasty because you can collapse the pyramid. But on the other hand, when it comes to preservation rhinoplasty, it is totally necessary movement because once you do sagittal osteotomy, you can easily reduce the hump without recurrence. This is how I use my piezo sagittal perpendicular to the maxillary bone surface, and I create the sliding surfaces. Then I can easily tilt the pyramid to the midline. Of course, when it comes to crooked nose correction, you need to release the periosteum inside of the maxillary bone exactly on the contra side, other side of the deviation, because you need space to tilt the pyramid and overlap, and you need to resect the piece of inferior turbinate bone or Webster triangle because you need space again to tilt the pyramid to the midline. And then after resection of the Webster triangle, once you push to dorsum, you can easily tilt the dorsum to the midline. If you don't resect the Webster triangle on the uncrooked side, you cannot overlap the Webster triangle over the inferior turbinate bone fragment. It is very important issue actually because the Webster described this triangle for preserving the airway. Because in structural rhinoplasty, The reason of osteotomies are different than the preservation. We are trying to impact the pyramid in preservation rhinoplasty with osteotomies, but in structural rhinoplasty, we are trying to close the roof and narrowing the base. So the philosophy is totally different, reason is totally different. That's why when it comes to preservation rhinoplasty, we don't need to preserve the Webster triangle, we need to excise the Webster triangle. This is the diagram, how it works. This red line can be exactly on the borderline between the junction with ethmoid bone, but basically, if there is a hump and if we want to reduce the hump, it is better to make this cut exactly on the most prominent portion of the hump, and we need to excise a strip from the ethmoid on the top of the septum, and we need to excise a piece of septum from the base. Then we can release all the tension and we can change the direction easily. So why I'm talking about low septal strip? Actually, in my practice, I do a lot of high septal strip. It is easier, and for beginners, it is actually very simple to learn. But on the other hand, when it comes to crooked nose correction, we need to separate the nose from the bone around. So that's why low septal strip basically better for crooked nose correction. This is from the cadaveric dissection course. Look at the base of the quadrangular cartilage. There is an excessive portion, which we always deal with this kind of deviated noses. Once you excise this excessive portion from the base, you can release the tension of the quadrangular cartilage and you can easily separate from the ethmoid bone, and you can change the direction and you can fix back to the anterior nasal spine. At the beginning of the lecture, I was showing you a lot of skull photographs. Then you remember that anterior nasal spine is almost always on the midline of the bony skeleton. So we have to check the soft tissue envelope midline, and we have to understand the relationship between the anterior nasal spine and the midpoint of the lip. If they are on the midline, if they are exactly on the same line, we can use the position of the anterior nasal spine. If not, we can tilt our quadrangular cartilage to the right or left side of anterior nasal spine. We can create the knee groove and we can make the straighter nose. So when it comes to low septal strip, the section plane is very important in my practice, because in first 1 centimeter of the septum here, as you can see, I marked here, this is the supraperichondrial dissection I do on the septum. So when I start my dissection on the septum, I use the supraperichondrial plane in first 1 centimeter because I need to anchor the caudal portion of the septum at the end of the surgery to the anterior nasal spine. As you can see here, this is the perichondrium. You can see the pink color of the perichondrium. Then I make a small incision to the perichondrium and I dive under the perichondrium. On this video, it is very obvious the difference between the subperichondrial and supraperichondrial plane. As you can see, once we go to subperichondrial plane, we can see whitish color of the cartilage, and I can easily harvest the cartilage in subperichondrial plane. This is the borderline between the supraperichondrial and the subperichondrial plane dissection. The reason I keep intact the perichondrium here for anchoring safely at the end of the surgery. And this plane, actually, when we learn septoplasty in our training period, our teachers were hitting our hands. It is not the correct plane, it is the wrong plane, because usually we do subperichondrial plane during the septoplasty. But when it comes to low septal strip, I prefer supraperichondrial plane in first 1 centimeter of the septum. Then once you release the septal cartilage from the bone around, as you can see, it's like mold. You can tilt the nose to the midline, you can fix everywhere. It is very easy. So this is the example of low septal strip. As you see, the nose is crooked to the right side. When I release the septal cartilage from all around the bone, I can easily tilt the pyramid to the midline. Of course, if there is hump, you can deal with the hump. Depends how much resection you do from the base. This is also another example. As you see, the face is asymmetrical, And it is very good candidate for low septal strip because even most of the patients, I don't do dissection on the dorsum. So skin is attached, all the ligaments are attached. I just tilt the nose to the midline so you can easily make the crooked nose correction. This is the video of the patient with the genioplasty together. This is another example. As you see, the nose goes to the left. So once you separate the nose from bone around, then you can tilt the pyramid and fix to the midline. So most of the time I do use low septal strip when it comes to crooked nose. Of course, we need to discuss all other techniques because sometimes subdorsal flap, very slight deviations, C-type deviations we can use, and high septal strip we can use as a flap, or sometimes we can do resection and tilt the pyramid for slight deviations. But if the ethmoid bone deviation is obvious, we need to separate the quadrangular cartilage from the ethmoid bone because ethmoid bone deviation is our enemy when we are dealing with the crooked nose correction. This is another example. The nose goes to the left. When I separate and make the right side sagittal, left side horizontal osteotomy, I tilt the pyramid to the midline. This is another example, very good example for this low septal strip. No dissection at all on the dorsum, no skin dissection. Just I create a tunnel on the base of the pyramid. Of course, you need special instrumentation for that kind of approaches. You need special retractors, suction retractor. You need special long piezo insert. If you're using piezo, it is even better. I always use piezo for this approach because it is very precise. With classical instruments, you cannot predict the sagittal direction of osteotomies, but with piezo, you can easily cut the bone sagittally. As you can see here, when I tilt the pyramid to the midline, everything changes. And those dorsal aesthetic lines are patient's own. But when it comes to the midline, even reflection of the dorsal aesthetic lines are changing. This is interesting example. This is not before and after. This is just before with flash and with paraflash to understand and underline better the deformity. This patient had previous rhinoplasty and she had very thick skin. She was just complaining about crooked nose correction. Why I'm showing here? Because preservation rhinoplasty has limitation. We always think that it is just for the primary rhinoplasty. But when it comes to crooked nose correction, if the previous surgery was done by structure technique, and if the dorsal aesthetic lines are not bad, if the patient doesn't complain, if she complains just about the crookedness, and side view is actually not bad, she was not complaining about the side view, she was just complaining about the direction of the nose, then as you see here, septum is not on the midline. So the question is, if we do preservation rhinoplasty on previous operated noses with structured rhinoplasty, does it work? Is it safe or not? So this is the example. What I did here, I didn't do the dorsal dissection. I just created the osteotomy tunnels. One side sagittal, another side horizontal osteotomy. As you can see, the sagittal osteotomy side, I excise the Webster triangle, I release the periosteum, and I tilt all the pyramid to the midline. Then I fix the caudal portion of the septum to the intranasal spine again. So how it works, actually, she's so happy. A small touch-up operation, just with preservation technique. You just need to know where to separate, how to deal with. This is the side view, a little bit changed, but not too much when you put the septum to the midline. Easier operation. And of course, you have to deal with the crookedness of the septum sometimes because sometimes the shape of the quadrangular cartilage is also crooked. So you can deal with structural rhinoplasty easily, but on the other hand, you are dealing with preservation rhinoplasty the same way because what we are doing here, if the quadrangular cartilage has C-type deviation like this, if you release from the bone around, sometimes you cannot change the shape of the cartilage because it is very difficult. Then what I do, preservation or structure, it doesn't matter. I use exactly the same technique. I just score the cartilage and I break one by one all that scoring lines. So first of all, I kill the memory of the crooked septum. Then I splint it with the additional cartilage or sometimes with the perpendicular plate of the ethmoid bone, a piece of bone very helpful. This is, for example, the example for the revision rhinoplasty case. As you can see, L strut was protected before. Then I just score the cartilage. Then when it comes to crooked nose, you have to kill the memory of the cartilage. It is very important. And it looks a little bit aggressive, but it works wonderful. You have to break all that scoring lines one by one. If you don't break, it doesn't work. As you can see, I just break the cartilage, then it looks already straighter, but it is better to splint. So you can find a piece of ethmoid bone, or you can use rib cartilage. If it's the revision rhinoplasty, most of the time I harvest the rib. You can use this rib oblique version. Oblique version is much better than the spreader grafts when it comes to crooked nose. Imagine that you're the carpenter and working on the table, and just when you flip-flop the table, if you look at the legs, they use kind of oblique additional piece to fix the legs. So this is very important to split the septum from the ethmoid bone deviation. On this photograph, you see totally different design of the septum work, because I was talking about the low septal strip. Low septal strip means that you're releasing the septum from the base and separating the septum from the bone around, ethmoid bone, vomer, and the maxillary bone. But some noses, we have crooked noses. The nose is deviated to the one side, but the pathology is not affecting to the base. And the question is why we need to release all the quadrangular cartilage from the base in this case. We can combine with structural techniques. We can split the upper lateral cartilages from the quadrangular cartilage. Instead of resecting from the base, we can make the resection from the top between the upper lateral cartilages. Imagine that you have this kind of crooked nose. Look at the base photograph on the right side, and there is no pathology on the base. So we don't need to release all the septum from the base, but we need to release from the ethmoid bone. We have to separate the relationship between the ethmoid bone and quadrangular cartilage. If patient has hump, we need to excise. If patient doesn't have any hump, just separating from the ethmoid bone is most of the time enough. Look at this design of the septoplasty. I call it bony preservation. I published in PRS. So look at this design. This is the most prominent portion of the hump. And once you make the chondrotomy, immediately under this most prominent portion, you can harvest this piece of cartilage, but the base of the quadrangular cartilage is saved. So I don't disarticulate the base. I just disarticulate the ethmoid bone. With this maneuver, my septum is free of ethmoid bone and the base doesn't have pathology. I can tilt the pyramid to the right or left. If there is hump, I split the upper lateral cartilages from the quadrangular cartilage, like structural rhinoplasty. In between upper lateral cartilages, as you can see here, I just push the bony pyramid. I keep intact the bony pyramid, but I resect the quadrangular cartilage in between the upper lateral cartilages. So you can fix back the upper lateral cartilages with 6-0 PDS, then you can finalize your surgery. And you can tilt the pyramid to the right or left. Of course, not for all patients, but some patients needs less surgery. So this is the reason that we have another option to make this kind of bony preservation rhinoplasty. I have the 3D animation of the technique. This is more understandable, especially when it comes to crooked nose. The main reason that we are doing the septoplasty is separating from the ethmoid bone deviation. In case if there is no pathology on the base of the quadrangular cartilage, we don't need to release the septum from the base. We can release the septum from the upper lateral cartilages. As you can see here, directly chondrotomy immediately under the most prominent portion of the hump, and excising the piece of ethmoid bone immediately under the bony hump, and bony pyramid is saved. And once you split the upper lateral cartilages from the quadrangular cartilage, once you push down or let down, the quadrangular cartilage delivers in between the upper lateral cartilages. Then you can trim and excise easily as much as you need. And you have to complete your low-to-low osteotomy, radix osteotomy. Now we will see the position from the side. Look at the left side. Once you push down, you can tilt the pyramid to the right or left. And ethmoid bone deviation is not your enemy anymore because you split the ethmoid bone from the quadrangular cartilage. Then you can excise the excessive portion of the septum in between the upper laterals. Saving the upper laterals are important. You're not excising any piece of upper lateral cartilages. You're just excising the quadrangular cartilage. Of course, the ballerina maneuver, which I described for preservation rhinoplasty, is very important when it comes to dorsal preservation. But if you're using bony preservation, like I showed in the last video, it is forbidden to make ballerina maneuver because it is the only one structure that keeps all the dorsum intact because we split the septum from the upper lateral cartilages in this technique. It's a very important point. So this is an example which I made with the dorsal preservation. With bony preservation, I split the septal cartilage from the upper lateral cartilages. And preservation rhinoplasty is a very good tool to make the crooked nose correction, but it has limitations, especially when it comes to traumatic noses like this. I mostly prefer structural rhinoplasty because I need to change all the dorsal aesthetic lines and I need to reconstruct the nose. Sometimes you need rib cartilage. This is an interesting case. I'm just showing you to understand our limits because for beginners, I don't really recommend to start with this kind of cases in preservation rhinoplasty. But on the other hand, if you have experience, sometimes this kind of noses can be treated with even preservation rhinoplasty, and sometimes it is easier with preservation rhinoplasty. This case is interesting case. He was my live surgery case 5 years ago, and it was written in the program that I'm going to do with open structure rhinoplasty. And my moderator was from Turkey, Dr. Tevfik. He was asking me when I was in the operation theater, Dr. Göksel, are you going to do preservation? And it was written open structure. And I became a little bit nervous and I asked him, are you kidding? It's not possible to make preservation. This case is very good candidate for structure rhinoplasty. So this is the simulation before the surgery. Okay, let's make it without sounds. So operation started. I decided to do open structure rhinoplasty. As you see, the septum was totally crooked, so I was planning to harvest the septal cartilage, and it was not planned for rib harvesting. It was the primary case in the live surgery course. Everything was so smooth. I was opening the nose. Then I approached the septum in between the medial cruras. So when I approached the septal cartilage, now you will see the septal cartilage was totally broken, but it was not surprise, it was actually expected. The surprise was behind of this broken line, there was no cartilage. It was totally ethmoid bone. So when you come to this point, you're thinking twice during the surgery. Sometimes you need to change your plan. This is the broken part, and immediately behind of this breaking line, there is just bone. So no cartilage to harvest. So I turn back to my moderator and I ask him, maybe you're right. Maybe we can go with the preservation rhinoplasty in this case. Otherwise, I need to harvest the rib. Then I look at the dorsum again. And when I look at the dorsum again, the dorsum started to look at me nicer. So I decided to make sagittal osteotomy on the left side. As you can see, the Webster triangle excision on the left side of the pyramid because the nose was totally crooked to the right side. And after the resection of the Webster, I changed the direction of my insert sagittally. So I cut the bone sagittally on the left side. The difficulty of the case, he had no hump. So there was no hump to reduce. or change the shape of the lateral side view. That's why I totally make the horizontal osteotomy on the right side of the bony pyramid. As you can see here, this is the horizontal osteotomy. Then, of course, when it comes to radix osteotomy, I don't prefer to cut with piezo. I prefer 2 mm osteotomes because I want to break the radix instead of cutting the radix, because radix point is my hinge. I don't want to change the height of the radix most of the patients. So then this is the radix osteotomy with the 2 mm osteotome, totally oblique direction, because oblique osteotomy makes the hinge at the radix, and you will see with endoscope how it works. The nose was crooked about 1 cm from the midline, so we need to change the direction of the nose without changing the lateral view. As you can see on the left side, this is the sagittal osteotomy, and I release the periosteum because we need to overlap on the left side, but we don't need to change the height. That's why on the other side it was horizontal osteotomy. Then with the fingers, you can change the direction of the nose after all these maneuvers were completed. But the problem was dorsal aesthetic lines, first of all, and the second, the caudal portion of the septum was totally crooked. As you can see, this is the radix osteotomy, at least 5-6 mm position change from right to the left. Then I decided to polish all the dorsal aesthetic lines. I'm showing this example for understanding the limits of preservation when it comes to crooked nose correction, because you can do preservation rhinoplasty, you can preserve the integrity of the middle vault, integrity of the bony pyramid and the cartilaginous pyramid. Then you can change the dorsal aesthetic lines. You can polish it with burr, with piezo, with a blade. So you can play with the dorsal aesthetic lines and you can change everything. You don't need to open the middle vault. It is better to keep intact the continuity of the anatomy. And when it comes to this kind of difficult cases, sometimes it is easier than structure, because with structure rhinoplasty, if you open the middle vault, you need spreader grafts, you need splinting grafts, you need extension grafts. So you need a lot of grafts to repair all that deformities. But with this approach, I just need to harvest the piece of ethmoid perpendicular plate for using splinting the crooked caudal portion of the septum. As you can see here, I harvested the ethmoid perpendicular plate, very nice straight bone, and I drill a hole with piezo. Then I use it for splinting the crooked portion of the caudal portion of the septum. As you can see here, this is the caudal portion of the septum. I usually use this graft on the concave side. So once you splint with the 5 OPDS, at least 5 different points, it should be strong. As you see, your caudal portion of the septum is already straight with this splinting. And as I showed you, the scoring and breaking maneuvers were done for deleting the memory of the cartilage. Then, of course, tipplasty, some grafting for the support to the tip. Then this is before and after. So the main idea, even this kind of noses, sometimes preservation rhinoplasty can be really helpful to find the solution and save our graft material, save patient's rib. Then we can solve the puzzle. So, as I mentioned, crooked nose correction is one of the most difficult part in rhinoplasty. And when it comes to asymmetric face crooked noses, I think the preservation rhinoplasty is kind of necessary technique that we have to learn. At least we have to keep all these knowledges in our toolbox, because when it comes for difficult noses, we need to use this knowledge from our toolbox as a rhinoplasty surgeon. Of course, structural rhinoplasty is the base of everything in rhinoplasty. We have to understand the philosophy. but preservation rhinoplasty is one of the best way to deal with crooked noses in my practice. So thank you so much for your attention. I hope it was helpful for participants. If there is any question, I'm ready to answer.
Yeah, dear participants, you can put your questions in the chat or in the Q&A.
Yeah, I see there's no question so far. While waiting for the participant to ask some question, may I ask Dr. Goskell with regards to the type of nasal deviation? Thank you for showing us a wonderful result and lecture on this concept of preservation rhinoplasty in managing deviated nose, deviated septum particularly. But I would like to ask if sometimes patient presented with a S-shaped nasal deformity, do you think there's a role for preservation rhinoplasty in this kind of noses?
As I showed you in the last example, it was kind of S-shape traumatic noses. When it comes to any deviated noses, first I prefer to think if I can deal with preservation rhinoplasty or not. Because if I feel that I can do it with preservation rhinoplasty, it is much easier instead of opening everything and reconstructing everything. But sometimes you're totally right. High septal deviations, broken septums can be the difficult for preservation rhinoplasty. I still do some structural rhinoplasties on crooked noses, especially if there is a bone collapse. If there is nothing to preserve on the bony pyramid, I prefer structural rhinoplasty. I prefer to make out fracture, in fracture, and spreader grafts, sometimes spreader flaps. But most of the crooked nose correction, I do use preservation rhinoplasty. It's kind of magic because once you get used, you're tilting the pyramid easily, then you're not reconstructing, you're just camouflating the dorsum. So even if you do structural rhinoplasty, most of the crooked noses at the end of the surgery, you need to make camouflage also because the dorsal aesthetic lines are not perfect in crooked noses.
Okay, we have one question. Okay, so it mentions that, can you please repeat when and why not to perform ballerina maneuver?
Okay, ballerina maneuver is very helpful to make the dorsum shape flat. So if you're dealing with the convex dorsum, without ballerina maneuver, you cannot easily change the shape of the dorsum. You can change the height of the dorsum easily with any other technique, but you cannot easily change the shape of the dorsum. I'm going to talk mostly this subject in cadaveric dissection. I will show how I'm doing in the course that we are organizing together in Thailand. But ballerina maneuver has two contraindications. The first contraindication is concave shape upper lateral cartilages, which is very rare in the population. But you can easily understand if the patient has concave shape upper lateral cartilages, if the middle wall is already collapsed and the shape of the upper lateral cartilages are concave, better not to do ballerina because once you release the lateral keystone, they can collapse more and you can end up with inverted V. It is very rare, but this is the contraindication, the first contraindication. The second contraindication is the bony preservation. Bony preservation means you're keeping the bony pyramid intact, but you're separating the relationship between the upper laterals and the septal cartilage. Then you're tilting the nose to the midline. But in this technique, you're not releasing the septum from the base. If you do additionally ballerina maneuver, you are separating all the upper laterals from the nasal bones, and there is no dorsal keystone which should hold the dorsum together, then you can create collapse. So two contraindication. First is the concave upper lateral cartilages. The second, if you're using the bony preservation technique.
Thank you. Can I ask with regards to this ballerina maneuver, when Dr. Goskell, when you perform the dissection on the nasal side, how far would you go? And on the pyriform at the nasal maxillary junction, how far would you go there?
Yeah, it's a very good question because it depends on the shape of the dorsum you want to change. If there is really convex shape of the dorsum, you need to extend your ballerina dissection up to dorsal aesthetic lines. So you need to feel your instrument on the dorsum, or if you open the nose, you can start from the dorsal aesthetic lines. Just the dorsal keystone should be intact. You have to release all the tension on the lateral keystone. And you have to separate the relationship between the upper laterals and the bone. Then, with the ballerina maneuver, it changed the shape this way. It is very logical and it's very easy to understand when you look at my hand. Ballerina maneuver makes this kind of effect. And if you want, I can repeat. It depends on the shape of the dorsum that you need to extend your ballerina. But most of the male patients, I don't extend my ballerina maneuver because the male patients needs a prominent dorsum, stronger dorsum. So I don't need to change from convex to concave. That's why I don't need to extend my ballerina. But most of the female patients, they like a little bit feminine effect. They like a little bit more curve. Then I do ballerina maneuver, a little bit extended version.
Right. Great. Thank you. Okay, we have
Leo, there
yeah.
are 9 questions in the Q&A. Can you go
Yeah,
to the
so
Q&A?
yeah, so yeah, I will go through. Okay, there's one from, okay, they were asking about in case of splitting after chondrotomies, would you add your cartilage graft on the chondrotomy site? Is this your
Yes.
rule? Yeah,
My chondroitum site is almost always on the concave side because I just make the chondrotomy and break the lines. So convex site was already narrow site. Then I don't want to put additional thickness to the narrower side. That's why I always put my splinting graft to the concave side. Then other side should be open. And Dr. If someone is here, thank you so much, Eve. He is my teacher. He is the great master of
he's
preservation.
here. Yeah,
Because of Eve, we are talking about preservation rhinoplasty. He taught me how to do high-septal I'm still doing 90% of my cases with high-septal and it is very helpful in my practice. Thank you, Eve. And he is
and
asking
then
another question
on
right
the
now.
same participant just now they asked, he also asked about the bony head resection of the inferior turbinates on the side of tilted nose. That I think that's talking about the Webster area. Are
Yes,
you doing that often?
we have two options. Usually Webster triangle excision is easier to make it, so you don't need even piezo for it. You need to just grab with some ronger. You can excise easily. Or if the inferior turbinate bony fragment is blocking the airway, sometimes I do excise also the inferior turbinate bony fragment together with the Webster. It's actually the same region. That's why when I was talking about that region, Webster's triangle excision or inferior turbinate bony fragment, but you need to excise a piece of bone to impact the pyramid inside of the maxillary bone.
Actually, there are quite a number of questions. So there's one more here. Okay, they were asking about how can I suture the quadrangle cartilage side to the side of the spina nasalis without tilting? Because in some cases, the suture deviates the septum again.
Most of the time, we do create groove, so I suture to the groove. And there is a actually small trick when you do low septal strip. eh, Most of the ENT surgeons are get used to separate all the base from the soft tissue. So that's why at the end of the surgery, you need to create groove and you need to fix tightly. So you need fixation, very strong fixation. But on the other hand, if you don't separate the soft tissue from the intranasal spine around, your septum cannot go to the right or left. It's on the midline. So you can just put the stitch to the soft tissue. And if it needs to change the direction from the midline to the side or left of the internasal spine, you need to put side to side. Then you need to drill a hole to the internasal spine so you can pass through that hole. It is also easy. And I don't use piezo for drilling hole to the anterior nasal spine most of the time because I do limited dissection. I drill a hole with needle. It's also very fast procedure. You don't need any power instrument for it.
And okay, thank you. And then there's another question is with regards to the difference in your decision making between the post-traumatic deviation of the quadrant cartilage fracture versus congenital deviation with tension cartilage. I think he's talking about the
Yeah,
tension
yeah,
nose deformities.
it is very good question. The last example I showed, it was traumatic nose. It was broken septum. So I was always thinking that if there is trauma, first we need to go with structural rhinoplasty techniques. But by the time when you get your own experiences, what I learned, even for traumatic noses, we can easily use splinting grafts because we do the same for structural rhinoplasty. We can use the splinting grafts and we can still use high septal strip, we can still use low septal strip, we can still use combinations. So the most important part is the ethmoid bone deviation for me because once we go with the structural rhinoplasty, it is not easy to deal with the deviation of the ethmoid bone. So we have the limitations and we have to do a lot of different maneuvers to delete this memory. And when it comes to traumatic nose, it's exactly the same. If the septum is, if there is possibility to make the septum flat with some splinting grafts, and if I have material to make the splinting the septum, I prefer still preservation.
Okay, so let me see. There are a few more questions here. Okay,
I
okay,
think
let
there
me.
we can maybe take about two more final
Yeah, I
questions.
think we take about two more. Yeah.
Mm.
Yeah, let me see. Yeah. Okay, there's one with how do you deal with the lateral side wall if it is a concave on one side and convex on the other side in case of
Yeah,
the crooked nose?
probably this question is about the bony pyramid convexity
Yes.
and yes. Uh, if you have piezo, it is easier because with piezo you cannot harm the internal periosteum, so you can design your osteotomies. I do sometimes crisscross osteotomy and I change the convexity to flat easily. Sometimes bone is thick enough, you can just do osteoplasty. You can use hand rasps, you can use burr, you can use piezo, you can make flattening on the surface. But when it's come to concave, it is little different than the other because concave is more difficult to treat. And sometimes crisscross osteotomy is helpful to make the concavity to flat again, but you have to put some additional supportive tampon underneath for 1 week. Or I use the camouflage grafting on the concave side to cover the surface.
Okay, I think we can have one more last question here. So it's talking about asking about how do you deal with asymmetric medial and lateral crust in a crooked nose deformities?
Yeah, it is the missing part of this talk because I had
Yeah.
just 40, 45 minutes. As I mentioned at the beginning, when it comes to crooked nose, we can talk days and days because it's about the lateral crura shape, it's about the tip plus the
Soft tissue
middle
muscles.
of,
Yeah.
but shortcut, I can let you know my approach for the lateral cruras. If I'm doing preservation rhinoplasty, most of the patients I prefer to preserve also ligament connections, so I prefer to preserve the scroll. But when it comes to crooked nose correction, I'm not obsessed about the ligament preservation. I'm obsessed about the shape of the skeleton. So about the lateral crura, concavity and convexity is the most important part in tip plasty when it comes to crooked nose because most of the crooked noses has asymmetric length and asymmetric shape of the lateral cruras. So you need to change the tip direction this way. So most of the time you need to overlap the tail of the lateral crura with the accessory cartilage. Then you need to change the length first of all. Once you change the length, you need to check the shape of the lateral crura. If one is convex, another is concave. Most of the time, if I dissect the scroll, depends on the shape and the thickness of the cartilage and structural support of the cartilage. I use turn over for the convex side, turn under for the concave side. because turn under and turn over, they are different. So they are not the both same, because turn over works better for the convex side, turn under works better for the concave side. Or if you have enough material, still I do use structural tip plastic techniques. You can use lateral cross strut grafts. And if it's really obvious and significant asymmetry and the shape is very stiff, the tissue is very stiff, the cartilaginous tissue is very stiff, sometimes I do use flip-flop technique. I just excise the lateral crura, make it flip-flop and put it back and support with the lateral cross strut graft. But there are a lot of configurations, and very rarely I do slide under maneuver when it comes to crooked nose correction, because slide under for me on the right and left side doesn't work the same for concave and convex, and most of the crooked noses needs different maneuvers on the both side.
Great. So I think we are coming to the end of our webinar today. As usual, we would like to congratulate Dr. Göksel for the wonderful presentation, as well as our appreciation for his time to present this topic, one of the very challenging topic in rhinoplasty, that's a crooked nose deformity management. So with that, I would like to thank Göksel in the usual way, okay, and also would like to pass this meeting to Mr. Eddie Liu. So he will say some final words on that.
Okay,
Thank you.
thank you very much, Dr. Liao, and of course, Dr. Göksel. Today, we have a very phenomenal registration. We have about 300 registration with actually 150 actually attend at this hour of time for most of the Asia, a late evening. So it's a very good turnout. So thank you very much, gentlemen, and to all the enthusiastic participants. As you can see we are so privileged and we are so happy to have invited all the most prominent surgeon in rhinoplasty coming our inaugural nose by FATS. We have, of course, the distinguished Saban, Terumi, Göksel, Jong, Dr. Liao, Ecuador Yap, Lehan, Teoku, and Kidakon to join us for the upcoming July meeting in Bangkok. We have 2 days of a lecture, and we have the final day of a hands-on cadaver workshop, and we have actually prepared for observation and also hands-on. So as you can see, for the key topics are listed below. These are most of the discussion. Anybody who are interested can register through our website www.fats.mind. All right.
Thank you so much, Eddie. Thank you so much, Dr. Leo. It was my pleasure to be with you, with all participants. Thank you for the questions.
Yes, thank you very much, Göksel. It's early evening to you, and it's quite a late evening to most of the Asia part of this part, and even more late for our Australian counterparts. It's almost early morning in Australia. So without further ado, thank you very much, Göksel. Thank you very much, Dr. Liao, and also Saban and everybody.
Good night, everyone. Thank you so much.
Good night, everybody. Thank you.